for these very thought-provoking presentations. I really find cardiology always fascinating. It might be its challenging nature. So we haven't got too many questions to ask. Actually, hasn't come up from the attendees, but really we have quite a few questions to ask from the other speakers. So the first question is to Dr. Mary. Hello.
I'm here.
Yeah. Okay. Yes. Well, coming to these antenatal diagnoses, well, obviously your system is much ahead of us in terms of providing these invasive cardiology services in the neonatal unit, and even you thinking about getting these stuff into the labor ward. But what's your percentage of antenatal diagnoses, especially the critical congenital heart diseases?
That's a good question, and it varies across the United States. Looking at a study that came out of the STS database, which is really those kids with congenital heart disease that need surgery in the first month of life. So it's the important heart defect. The overall detection rate was somewhere around 30 or 40%. And it definitely gets better every year, but it still is a challenge. And there was a lot of variability depending on what part of the country you were in. In our region, it was actually at the highest at about 40%, which is unsettling to me because my goal is 100% prenatal diagnosis.
Yeah.
My partners recently led an initiative with what we call the Fetal Heart Society, which is an international research organization that I'm currently the president of, but it creates an infrastructure for studying fetal cardiology. And what we found was that when looking at, for example, hypoplastic left heart, the detection rate was nearly 100%. So we're good with those complex single ventricles, but for transposition of the great arteries, it was less, somewhere around 60%, and definitely had some variability. Socioeconomic status, ethnicity were all barriers to diagnosis. So I guess in summary, the heart defects in which the four-chamber view is normal are the ones that we're going to miss. And so that's transposition. And then the single ventricles are much more often detected. And what I mean is we're going to mean whoever's doing the screening. So once you make it to a cardiologist, we're 100%. We can really see the details of the diagnosis. Our challenge is working with the obstetricians and the radiologists who do the screening. And so there's lots of initiatives to improve detection. So I would say currently this is one of our goals in our current unit. I would say about 60 or 70% are prenatally diagnosed.
But I think that's one issue. But how do you deal with these undiagnosed surprise coming in a smaller unit? I'm asking because of the way that we have the setup and the way we are trying to manage these things. How you manage, because you always have a big setup most of the time. Cardiologists are available in a bigger unit. How you manage these things in a smaller unit? If what kind of skill level your radiologist involved in antenatal scan, what kind of skill level they have, so and how you deal with these such issues in the peripheral area.
Right. And I think I'll start the conversation, but this is certainly something that Billie and John can jump in on. You know, as I said, our goal is to work with the obstetricians for 100% diagnosis. Obviously, we're not there yet. So first thing to say is when we look at congenital heart disease, the fancy things that I was talking about are just really a small number of patients. So maybe it's about 10% of those really require very specialized care in the delivery room. The majority, you know, if congenital heart disease is suspected, the ductus doesn't close right away. And so, you know, typically you can get some sort of line in. Most hospitals now have prostaglandin. But that certainly is a problem in some of the very remote hospitals that prostaglandin isn't even present. The reassuring thing is that the duct doesn't close for at least a day. So if you suspect congenital heart disease, you should initiate transfer as quickly as possible. And then there's a huge percentage of these patients that are the level ones, which, they slowly get sick over time. So I think our initiative is really, first off, to just make people aware that it should be in the differential diagnosis. We have something called pulse oximetry screening in the United States, which means that within the first 24 to 48 hours, an upper and lower extremity pulse ox needs to be obtained on every single newborn, which can certainly identify patients with congenital heart disease. And then that sort of initiates a process to figure out why this kid's newborn oxygenation isn't normal. We created the protocols that I reported at the end. That paper, the supplements to that paper include all of our, protocols for these high-risk disease. And the reason we did that was for those patients who don't make it to us to deliver, where I can be in the delivery room, can I give the neonatologist something to do, a process to hang on to that we would do. And so how I started that was I asked John, if you were standing in the delivery room, Dr. Berger, what would you do to stabilize the circulation? And then that started that flow diagram or that list of do this, this, and this. And then I gave it to Billie's partners and said, okay, well, this is what the cardiology intensivist would do. How is, in your mind, does that work for the neonatologist? And so working as a team, we were at least able to get some guidelines. So I guess the answer is you definitely need suspicion. Pulse oximetry screening has really helped us identify patients before the duct discloses in most instances. And for these really sick kids, these flow protocols, diagrams that I think help at least get some of these kids to us without extreme brain injury. I don't know, Billie and John, do you want to add to that?
Thank you very much.
I'll just jump in and then I'll let John. But I think we get babies transferred from 40 different hospitals, so we'll get the call, and from these very small hospitals, we haven't had, I think, the same ability to get good ultrasound diagnosis. So the kid will come out undiagnosed for anything, actually, and have to a 40, 40, 40, 40, despite what they do. If they intubate, it's 40. So that's a typical cardiac patient, but we also have found that a great percentage of those are idiopathic pulmonary hypertension. So our Mary has worked extensively, and John, with our transport team, so they will be prepared to take prostaglandins with them for that type patient. We tend to still, if it's not totally clear, bring the kids to the NICU, get the echo. If it's heart echo, they can get transferred to our cardiac unit. But I think it's the teamwork that's made that possible, and it's our team. Mary trains our transport nurses, and John also in management of these kids, so they're prepared. And thinking about it, I think that's what Mary's point was. You have to always think about it as a possible diagnosis for a kid who comes out looking like a potential respiratory kid. All right, John.
I just wanted to ask other questions. Being a neonatologist and not asking about the PDA, this is the problem which we come across in our neonatal intensive care units. And you being a chief for neonatology, I expect that you have been dealing with these issues more frequently than others, your colleague. One issue about the PDA management is that we don't know the natural history, especially in our preterm babies. And sometimes my initial feeling was there was a time when we were trying to close it as early as possible, even prophylaxis, and then moved away from this approach. And now if patient has got a significant PDA or a stuck on a mechanical ventilation, then we treat it. Otherwise, if they are staying on the non-invasive ventilation, there's no rush to. But we are coming across in a situations where, yes, patient has got a PDA, which is significant on even echocardiogram, but patient is extubated, stable on nasal CPAP. What we are going to get out of it? But we come across in a situation in that kind of patient that if we do not close, it might close at 30, 32 weeks. It might not close even at 35 weeks, and he's still on small amount of oxygen. And he, in setup like us, he might need closing the duct, ligating the duct before going home. He might need a surgery. So in what he could have been treated, if we look at retrospect, he could have been treated with some ibuprofen or paracetamol, then waiting for such a long time. So how long we should wait in such a situation if they have been extubated on CPAP, the duct is significant? What should we do, or what you should do, what you do in such a situation?
I'll say from the neonatology standpoint, John can talk about cardiology. I think if they still have a large and moderate PDA, even on CPAP, we recommend closing it. We do have the small piccolo catheters now to do with cath lab closure, but that's size dependent. My concern, and again, we'll watch the kids for a while, and John will jump in here because we have the cardiologist usually right there by our sides doing the echo and telling us what they feel. I worry about neonatology tends to always go a little bit in the one direction and then say, okay, don't worry about a duct at all. And those kids getting discharged and not getting follow-up and then ending up in eventually a cardiac office with pulmonary hypertension and all the complications of having flow changes. So I do worry, and we do, if we're leaving, not closing one, we make sure they have cardiac follow-up, to make sure that doesn't continue open if they come off of CPAP and things and it's still there. But I'll let my two cardiologists comment on that.
I would submit that if you are requiring non-invasive support and you're not growing well, you obviously need to close it. And these babies, if you don't close it before discharge, they require fairly close cardiology follow-up. In the sense that you've already got one risk factor for pulmonary hypertension in the fact that they're born prematurely. You add in chronic lung disease, that's the second risk factor. You add in a ductus arteriosus. It's not unheard of for me to see a kid who's been discharged from the hospital and has new onset of pulmonary hypertension 2 or 3 months after discharge, and they can be quite difficult to treat. And if they don't have close cardiology follow-up, these kids may not have much of a murmur, so it won't get picked up by a general pediatrician often. So, and some of the worst, I must say, some of the worst adolescents with pulmonary hypertension that I've seen, or some of the adolescents with the most severe pulmonary hypertension that I've seen in my career, have been those children who've had prematurity and a long-standing ductus.
But my question is, Dr. John, there will be a time in these preterm babies when this duct can be closed with just medications, and more you delay, less likely to respond to this medical treatment. So if the patient has been extubated on CPAP, should we treat it within 2 weeks or wait for a couple of weeks? And if not responding, to give it medications and see how baby respond to it?
that is a $64,000 question. It is a great debate in the literature. I think that obviously prophylactic closure beyond 7 days is not indicated anymore. I don't think we know the level of support that you should close it early. This is really a neonatology question, more than a cardiology one at that age. I think that if you're seeing any signs of pulmonary hypertension, with right to left ductal shunting or low velocity left to right shunting, then I think that's probably an indication to go ahead and get it closed earlier rather than later, regardless of the level of ventilatory support. And then, of course, if there's issues with growth, again, that's another indication for early therapy. I think for the other thing that's going to play into this, the risk of, people are more hesitant in this day and age to ligate a ductus surgically because we now understand that there's a significant risk of respiratory morbidity or airway morbidity. About 30% of patients will have vocal cord paralysis after ductal ligation with a premature infant. Where the cardiac catheterization-based intervention plays into this, I think it's going to make it a bit easier to close ductuses that don't respond to therapy that we might not otherwise close with surgery. And certainly the Piccolo device that Billie mentioned is sort of ideally placed in sort of that mid-range baby who's somewhere within the 800 to 1,500 gram range, and can be done with fairly low morbidity risk in experienced hands. So,
I think the gut perfusion and the weight gain is a big deal, and if it's still moderate to large, within my group, there's some early people that jump on board and some later, and I tend to be a little bit more early because I do feel it affects gut perfusion when you're trying to get feedings up and get these kids going. So I prefer to try to treat it. We now, again, with the Piccolo device, it's easier actually to say, well, let's just go ahead and close it because it's a cath lab procedure. We will use, indomethacin or ibuprofen to try to see if we can close it, and it's, variable. And but I do worry about the perfusion of the intestinal tract.
Dr. Billie, I have recently come across these kind of cases when a patient having a duct, and then they have got an ASD as well, then they are more likely to develop chronic lung disease depending on the ASD size and the duct size. So how we should deal with such a situation, in how big the ASD should be to allow us to expect that it will not cause a hemodynamic disturbance and we can wait, or how early we should close the duct in such a situation, having a PDA and a moderate size ASD or a PFO.
Yeah, the ASD I'm going to punt to my cardiologist because they will really determine, whether that needs to have any kind of a closure or anything. Most of those kids don't. In my experience, it's more the PDA that we have significant shunting to worry about. And I don't know, John, we usually, you'll get back, there's a PFO or a PD or an ASD. But we haven't had a lot of kids that we felt that's so significant that they need early closure.
I think there's two questions. I think you're asking two separate questions here. So the first question is, if you have a moderate or large ASD, is that another indication to go ahead and prophylactically or consider early treatment with medication to close a duct? And I would submit probably yes. Although I don't think there's a ton of literature that specifically asks that sort of question. That said, a lot of the moderate ductus or moderate ASDs will get smaller fairly quickly in the premature infant. So you might get away with it. I think the other question is, if you have a child with established bronchopulmonary dysplasia and moderate to large ASD plus minus pulmonary hypertension, do you go ahead and close that ASD surgically, which is really the only way you can do it in somebody less than about 10 kilos? And the answer to that question is probably yes. If you've got somebody with established BPD, and the literature suggests that if your shunt's anywhere above excessive pulmonary blood flow, 1.5 times systemic blood flow, a QPQS ratio of 1.5 to 1, you're likely to benefit from ASD closure. And there are papers, and certainly if I see a patient with a moderate to large ASD who's sort of heading down the path towards tracheostomy for severe PPD, we will often perform ASD closure, which resolves an element of pulmonary edema that the patients experience, and they can avoid a long tracheostomy. I think that's one of the important things. And if they have pulmonary hypertension, you might often see resolution or improvement in the pulmonary hypertension after ASD closure.
One more question. I know it's almost closing time now for this conference for today, but we do get patients with trisomy 21, and they do get congenital heart disease, especially complete AV septal defect. At what age you expect them to refer to cardiologists, or at cardiologists, at what age they want to see such patients in your setup? We usually hear, our UAE, they usually ask them, the cardiologists ask them to send us at 4 to 6 weeks. But recently I have come across a patient, trisomy 21, having quite a big AV septal defect, but he has got a population as well. And it is documented, reported cases that Downs baby do get along with that sometimes, not very common. So at what age they should be seen by, how early they should be seen by the cardiologist once they are born?
I mean,
or what do you expect? Yeah, please.
Yeah, I think it's a tough question because it depends is the answer. I mean, even when we know that there's a prenatal diagnosis of trisomy 21, it's interesting, even if we think the heart is normal on fetal ultrasound, we will see them post-delivery because there's some smaller defects that kids with trisomy 21 can have, like an ASD, for example, that sometimes it's hard to diagnose prenatally. So when you kind of look at the trisomy 21 group, about half of them have congenital heart disease. And of those, half have an AV septal defect. The other half have something else, whether it's a big VSD or an ASD or a ductus. I think it's important first to get them in so you know what their diagnosis is. And then you can plan the follow-up and the management, which would include surgery. The AV septal defects also are a variability to them. We talk about the valve being balanced over both ventricles. So if it's balanced, then you would expect symptoms of congestive heart failure maybe at 4 to 6 weeks of age. Sometimes the transition with the drop in PVR is a little bit longer, so maybe 2 to 3 months of age before you start to see symptoms. But the ones in which there's unbalance and ones that also can have arch obstruction or at least a small aortic arch, they're going to develop symptoms much sooner than that. So we've had patients that develop symptoms in the first couple weeks of life because all that blood is just dumping into the right side. And then the left side has some degree of obstruction, whether it's a true coarctation or just a small isthmus. I would say as a cardiologist, for just even the straightforward AV septal defect, if I don't see symptoms, I get more worried because that means you have persistence of pulmonary hypertension. And there is data, John knows better than me, the cutoff, but certainly the trisomy 21 kids are more likely to develop pulmonary vascular disease sooner than the kid without trisomy 21 and a big hole in the heart. So, usual is to try to manage them medically if they're in congestive heart failure, and then we refer them to surgery around 3 to 4 months of age. Sometimes they have to go sooner if they just have overwhelming symptoms. But the ones that don't develop symptoms are really the ones we worry about.
But what I'm asking is we do not get 100% trisomy 13 antenatally diagnosed. Most of our trisomy 13 are postnatally diagnosed. We do get.
Are you talking about 13 or 21?
Sorry, I got confused. 21. I'm talking 21, about 21.
Yeah. 21. So, yeah. I mean, I think the same applies, right? So if you see them in the nursery and it's a surprise diagnosis, we would do a cardiology consultation before they left the hospital.
Right.
And if they didn't, and if that wasn't possible, the referral to a cardiologist should be sometime within the first couple of weeks, just because of the variability I just mentioned.
Yeah, right. Okay, well, thank you very much. One last question to Dr. Billie. I hope my colleague organizer don't mind it. Dr. Billie, so you do deal newborns with on ECMO. We don't see many patients for ECMO, but sometimes patients with congenital diaphragmatic hernia or meconium aspiration syndromes, we have to refer them, or with pulmonary hypertensions. So at what point you want us, you expect neonatologists to refer this patient for the ECMO? I understand, yes, you have got ECMO in your own system, so you have a different kind of setup, but we have ECMO only in one center in let's say in Abu Dhabi Emirates. So at what point is it the oxygen index you take the criteria, or how you expect our neonatologist team at what stage we should refer? And the second thing is, what about their neurodevelopmental outcome? How you see this thing?
Yeah, that's an outstanding question, because that's what we deal with all the time. And I think what I recommend, most people use this oxygen index as an indicator for needing ECMO, and 40 is kind of the number that if they persistently are at 40, then they would be better to go on to ECMO. What I tell a referring hospital is you can't wait till it's 40, because then we have to put them in an ambulance and transport them. So you need a conversation with your ECMO center if your OI gets close to 30, which is, again, a kid on 100%, and the mean airway pressure, may still be low, but I think just a conversation helps, because what we do is we say, yeah, that kid's really starting, to go the wrong direction. Let's get him here first. And we have about half the kids that come don't go on ECMO, and it's better to do that and then get them back to the referral center once they're stable, than to have them coming in. We have one particular center I won't mention, but they'll be on nitric, on an oscillator, and a PO2 of 20 when they call us. And that's a kid. It's very dangerous to try to transport that type of patient. You've been able to do it, but that's the kid that will have the surgeon standing at the doorway when we get the kid in. So I think conversations, if you've got a good relationship with an ECMO center, once you're on 100%, once you're on maxed out, then what you consider maxed out ventilation, and most places now do have nitric, you need to call and say, well, the PO2 has now been 100, but if they start falling, down into the, most centers will call when the PO2s are like the 60 range on the maxed out ventilation so we can get into this. So it's not a totally good answer, but that's one I think. Conversations and getting them in earlier is actually safer than waiting really late. I forgot what your other question was.
Oh, the neurodevelopmental outcome in patients when you put them on ECMO, especially the meconium aspiration syndrome. I know you don't put CDH, and what about PPH and patient as well?
Yeah, actually, most of the patients now are CDHs because we're keeping most of the meconiums off, although if there's a handful that go on. It's actually pretty good. The thing you have to watch, we had A nice study, but this was early in ECMO, and we're actually doing a lot safer with ECMO now. But 70% of the kids actually neurodevelopmentally look normal. You have to watch stool age. What we found is at 5 years, even though they were looking good at 2 years, which is where NIA, at least our Institute of Health, stops, won't pay you to go beyond that, but we were able to get a 5-year study. About 40% were testing that they might need special schooling and more of a school issue, not having major, developmental or neuromuscular issues, but having learning disabilities when they went to school. So they need to be followed closely. There's interesting. There's only one adult paper that was a questionnaire sent out, and the thing I worried about, and my cardiologist colleagues down there, is especially the idiopathic pulmonary hypertension. Are they going to be the adults who then develop pulmonary hypertension or develop it as an adult? And so far, it does not appear, but no one knows because they're just getting into the 20 to 25 year age now. So it's still not determined, but something to worry about.
Okay, well, thank you very much.